Excellent. Thank you so much for taking time to join. Let me share my screen with you, then we can proceed. I've just disabled my video because the internet is a little bit unstable on my side. I think you can now all see my screen. I don't have many slides, but I have a lot of things to talk about. I'll start with the overgrowth syndrome, but I'm also going to transition to OMIM. I will explain what OMIM is, which is very important for all of us to know about OMIM, because the moment you begin scanning babies, you need to understand what OMIM is, because obviously you want to work out and know what is wrong with the baby. So I'll take you through the OMIM. It's a little bit confusing, a little bit, but I'm sure at the end of our time here, most of you will have a good knowledge of what OMIM is, because the moment we begin to talk of syndromes, we cannot continue talking about syndromes, start talking about OMIM. Last week, we did a syndromic approach, but we were dealing with the commonest chromosome abnormalities. But you all know that there are many genetic syndromes. The question is, when you are scanning a patient, how do you know which genetic syndrome is more likely? This is what we'll cover today on top of the overgrowth. So the overgrowth, there is basically the overgrowth. This is the approach that we should use. Whenever you come across a baby who is big, that is a large gestational age baby, which most of you are now able to identify. Whenever you say the baby is large gestational age, there are certain things that you have to do. We know we take a history. So whenever you meet a big baby, you just want to go back to your history first and foremost and ask the parents, if the parents are there with you, look at their size. Are they giants? Are they big people? If you have the privilege of coming across couples who know their birth weight, it's also worth asking their birth weight. Why am I saying this? Because parents who have probably a large build or big bodies are more likely to have big babies, right? Then we also have parents who have a high BMI. I'm sorry to say this, but those who are obese. So if you meet a mother who is obese women are more likely to have big babies. So history is important. Do not overlook the history of the patient you are scanning. You always have to reflect on the history. So anyone who scans baby should have a sixth sense. The sixth sense is the one that should always take you to the history to say, okay, who is this lady I'm putting my probe on? Do I know her enough for me to be able to make certain conclusions? If you don't know the patient you are scanning, you cannot make the correct conclusions most of the times in terms of your findings. So I can't overemphasize the history. This is why we want every patient we are scanning to be taken the history. You do not scan a patient you don't know. Please don't do that. Don't scan a patient you haven't taken the history. Take the history first. Know who you are scanning. Otherwise, you will institute a wrong care plan. So once the history is done and you have certified yourself that, look, this couple is not, they are not the descendants of Goliath and they are not super big, then now you have to verify the dates. Before you say the baby is big, verify the dates. Make sure that the woman's dates have been validated. If a first trimester has been done, like you now, most of you now know, we prefer that we use the first trimester dates. So if the woman has had the first trimester, please use the first trimester dates to assign this woman's date. Once you have validated the dates, if the dates are incorrect, then you have to redate the pregnancy using head circumference. And when do we normally see this problem of large vaginal age? It's very rare to see it in second trimester during the anomaly scan. If you see it in the anomaly scan, it's more likely that the dates are wrong. It's very rare to see overgrowth syndromes or babies who are bigger than 90th centile in second trimester. If you come across such a baby, in most cases, the dates are wrong. If the data are wrong, invariably, there will be some fetal defects. There will be some fetal defects, which we'll discuss more about as we go. What kind of fetal defects we are more likely to encounter whenever we see overgrowth babies. So, if there are no fetal defects in the anomaly scan, the baby is morphologically normal, and the baby is measuring large vaginal age, it is more likely that they have a wrong date, unless if they're the first trimester. Even if they're the first trimester and you do not have any access to the image of the CRL done, because if it is done by somebody who is not very competent, the CRL can be grossly over or underestimated in non-competent hands. Because if the baby is measured on an oblique, the top of the crown and the rump and the bottom of the rump are not the ones used as the fixing points on measuring CRL, then surely you could have a baby who is wrongly dated, even with the first trimester. So if you do not have the image of the CRL that was done, you should still query the dates if you see a large for gestational age baby who is morphologically normal in second trimester. However, the situation is different for third trimester. So if you see a baby who is large for gestational age in third trimester, it is more likely that and you have validated the dates and you have looked at the couple size or their birth weight, if you have access to that information, and if you have certified yourself that they are not giants themselves, and if you meet this big baby, it is more likely that indeed you are dealing with a true LGA, a true large vaginal age baby. The first step is to screen for diabetes. Those of you who have been in the specialist clinics, you have seen us ordering a lot of OGTTs, so that most of you should know what an OGTT is by now. So if you do a scan and you see that the baby is large vaginal age, the next step is to check for diabetes. Even if the woman does not have a family history of diabetes, you still go on and screen for gestation diabetes, or even for ovarian diabetes, because most women we see in our units, probably they rarely have any form of testing outside the pregnancy. So diabetes can exist as a silent disease in a big proportion of people. So because of this, you still go on and screen for diabetes. So you order an oral glucose tolerance test, because diabetes is the disease to exclude, because it's the most commonest of the pathological causes, right? Of the maternal causes, let's say of the maternal causes, the most commonest of the maternal causes, after, of course, constitutional and wrong dates, then what follows there is diabetes. And diabetes is a disease to rule out in every big baby. So if you are scanning a patient in the routine clinic and you suspect that the baby is large vaginal age and you feel you want to refer to the specialist clinic, before you do that, make sure you have ordered an OGTT, so that when the patient comes to us, they already have an OGTT done, an oral glucose tolerance test. So when you order an oral glucose tolerance test, remember it's a test that is to be done at the laboratory. And for this test to be done, the woman should fast for a minimum of 8 hours. So normally they should fast from 12 midnight and they go to the laboratory around 7-ish, so that by 8 o'clock they have their fasting blood taken and they'll be given 75 grams of glucose. And after 2 hours, the lab should check again their blood glucose level. In pregnancy, we do not worry about the 30 minutes, the 1 minute hour, the 1.5 hours that some laboratories do. So, which means we have to specify on the request form that we want the fasting and the 2-hour one, so that the woman is not pricked unnecessarily. Because there are some laboratories that want to take 6 times of blood samples, 6 blood samples from the woman just to do an OGTT. But in pregnancy, we know that the fasting in the 2 hours is good enough for us. So there is no need for the woman to suffer these other 4 blood draws. So you should state on your form that you want the fasting and the 2-hour glucose when you order the OGTT. That is very important. If you just write OGTT, honestly, having your blood taken 6 times is not a job. So after excluding diabetes, and we are certain that there's no diabetes, we now begin to think of the overgrowth syndromes. This is what Diana and her colleague recommended, Diana Bianchi from America, recommend that you now have to do a targeted ultrasound. So in this targeted ultrasound, how can we help to triage and know which syndromes we are dealing with? The overgrowth syndromes are more than what you are looking at. I'll show you when you do the OMIM together. So let's start here. You see that there is a large positional age and there are other congenital abnormalities. But amongst the congenital abnormalities, you have congenital diaphragmatic hernia. Sorry, just give me a second. So amongst the congenital abnormalities, you have a diaphragmatic hernia, you have a post-axial polydactyly, and you have ventriculomegaly. If alpha fetal protein is done, you have an increased alpha fetal protein. If it was done in the 2nd trimester, is an unemployed screening. In that case, you should consider a syndrome called Simpson-Golabi-Bemel syndrome. Simpson-Golabi-Bemel syndrome. And the mother should be examined for evidence of mild phenotype if she shows any evidence of, a hugely built person. And if genetic testing is to be done, then we should request the lab to target the GPC3 sequencing to try and diagnose, to make a genetic diagnosis. So that's Simpson-Golabi-Bemel syndrome. I'll discuss this syndrome separately when we do the OMIM together. We'll go to these syndromes. Then we can have a situation where we have an overgrowth and brain abnormality. Then in that case, we need to consider Soto syndrome and orphokaryotype and fetal MRI. If we do FISH, we want our FISH to target 5q35. Now FISH has been replaced by QF, qualitative fluorescent PCR. So it will target the same region on the gene, 5q, on the chromosomes. So this is long arm of chromosome 5, region 3, subregion 5. So this is what we target, 5q35, especially if the patient is Japanese. Then also NSD1 sequencing is available to diagnose this syndrome. Then if we have normal growth or overgrowth and congenital diaphragmatic hernia and congenital heart disease and post-axial polydactyly. What is post-axial polydactyly? I think I mentioned it, but I didn't explain it. Post-axial polydactyly is when somebody has a 6th finger, but this 6th finger is on the side of the small finger. It's not on the side of the thumb. If the 6th finger is on the side of the thumb, it becomes pre-axial polydactyly. So post-axial polydactyly means the 6th finger is on the side of the small finger. close to the fifth finger, the smaller one, so it becomes polydactyl. This is why you see us taking the fingers and counting them. That is one of the reasons why people have to be their fingers whenever you are doing an anomaly scan. Don't underestimate the counting of fingers, because it will allow us to apply the syndromic approach, as you will see when you do the OMIM. Then consider Pallister-Killian syndrome and ophiokaryotype and FISH for deletion of the long arm, short arm of chromosome 12p. So that's a Pallister-Killian syndrome. Then we have overgrowth, which may not be prenatally present in certain cases, but in these babies, where they may be overgrowth, you could have omphalocele and also body asymmetry. It's not easy to sometimes pick this in the uterus, but you may see when you measure the limbs, both limbs, that there may be asymmetry in the size of the extremities, or the abdomen may not look very symmetrical if you compare the abdomens. Then we have polyhydramnios, we have renal and cardiac abnormalities associated in the large tongue and increase AFP, which is alpha fetoprotein. Then in that case, you have to consider Beckwith-Wiedemann syndrome, and we have to offer QFP-CRR, where we will be looking for a deletion on region 15 of the short arm of chromosome 11. So that's 11p, 15. I think the nomenclature of the chromosomes, when we were doing prenatal genetic tests, we covered a little bit of that. So I think those notes are valuable for those who may be wondering what are these numbers. But you need to know the nomenclature, because when the results come to you, they will come like that. So I've just gone through the syndromes, but some of you, this is probably a lot confusing to say. Then how do I know? How can I tell that in this case I've got Beckwith-Wiedemann syndrome, or I've got Pallister-Killian syndrome, or I've got Soto syndrome? Whenever I see defects, and you think that there is a genetic syndrome associated with the defect that you have seen, the question is, how can you know that this is not Simpson-Goldberg, this is not Perlman, this is not Soto, this is not Pallister-Killian? How can you know the syndrome? Or how can you know another new syndrome? You found the clinical features on the baby, but you don't know which syndrome to assign to this baby. Because if you don't know the syndrome to assign, you cannot order even a genetic testing, because the genetic testing, as you can see, that if you are suspecting that the baby has got Beckwith-Wiedemann, you have to tell the laboratory that I'm suspecting Beckwith-Wiedemann syndrome. Can you look for deletion on the short arm of chromosome 11 on region 15? Because the panels are so many so that the lab cannot just know that they need to go and look for a deletion on region 35 of the long arm of chromosome 5. The lab is not going to know that. So that means before you order a test, you want to have a rough idea of the possible genetic syndromes that should be looked for by the laboratory, so that you can narrow down the genetic syndromes to be tested. In other countries, the fetal medicine people, they do not have to worry about this. All they have to do is to send their report to a clinical geneticist. Then the geneticist will work through for them and tell them and order the kind of panels that have to be applied on the sample. But in our case, we are stuck. We do not have a geneticist to send to at the moment. One who is, well-versed with clinical, with prenatal diagnosis and so forth. So we do not have those people. So what do we do then? When we come across a baby who has these defects and we are wondering, what is this? How can we know? Then we have to go to the OMIM, the Online Mendelian Inheritance in Men. The OMIM. So it's an online Mendelian inheritance for men, which is continuously being updated by a group of fetal medicine people, geneticists, and many other people. So I'm going to stop the share. We're going to go to OMIM and show each other how do we use OMIM to arrive at some of those diagnoses that I've just mentioned there. So I'm going to stop the share. Then I'll reshare another screen here. Let me see. Right. So let me see. Just give me a second. Oh la la. Right. So I think I should reshare the screen now. So now let's go to OMIM. Please confirm that you are looking at a screen written OMIM. OMIM, if you just type OMIM on Google search, you're going to see this website, and you go straight to this website. It's an OMIM, which is an online Mendelian inheritance for men. Men for human, I mean, representing humans, not the phenotype men. So let's assume that you are scanning a baby. Let's take, for example, overgrowth. You have seen that your baby is overgrown, and you have written here fetal overgrowth. You want to see which conditions will give you overgrowth. I've put fetal overgrowth syndromes, and I'm now searching OMIM. So OMIM has just given me Beckwith-Wiedemann, but I'm not happy with Beckwith-Wiedemann. I want more. So what am I going to do? I'm going to remove the syndromes there and try the fetal overgrowth. Now you can see I now have a lot of conditions here that all will present with some overgrowth. When I look at these conditions, if I come to clinical synopsis, I hope my page is interacting with you where you are. Please let me know if it's not. If I go to the top right there, then I say clinical synopsis here. So if I click clinical synopsis, I'm going to select, I'll select Coastal syndrome here. Then I'll also go on and select Beckwith-Wiedemann. I'll select Perlman. Probably what else? Neurodevelopmental. Then we look and look. Right, I'm not going to go to the next page for demonstration purposes. So probably let's work with these three. Then I'm going to go to this tab written compare selected on the top right here where my arrow is. So I'm going to come here and say compare selected. So as I go online, now I have three of my conditions. I'm assuming that I've done the scan and I have a list of the abnormalities that I've picked up on the scan. So what do I have to do now? Now I'm going to compare and say which of these overgrowth syndromes that I'm presented with here will fit nicely into the baby that I'm looking at. Let me assume that probably the baby I've scanned has got micronathia, has got probably hepatomegaly, and probably let's assume that there is also hypoplastic nasal bone and maybe a heart defect as well, an AVSD or another heart defect. So all these conditions, except Perlman syndrome is autosomal recessive inherited pattern, the others have an autosomal dominant recessive pattern. This is not going to matter much for me because this is now for extrauterine, but this will matter as well for the neonatologists. They want to know the overall birth weight, but for us, it won't matter. Then hemihypertrophy is something I can pick on scan. So I'll check and say, do I have hemihypertrophy on top of the other defects I've mentioned? Macrosomia, of course, that's overgrowth. We see it in Perlman there. This one will give us macrocephaly. On my baby, probably I don't have macrocephaly. Prominent occiput, we could probably see this on scan. Large fontanelle, not much. Metropic ridge, not much. Coarse facial features, this is probably after birth. These are phenotypical issues. Mid-face hypoplasia may be slightly difficult to see on scan. Micronathia can be picked on scan, pointed chin. Then we have micronathia here as well. Unusual faces. If we do a very good 3D, maybe we may suspect, but not easy to pick on scan. This again is not easy. Low set ears, this may be picked on scan, low set ears. Then we have hypertelorism for this one, epicanthal fold, strabismus, ptosis. Ptosis, that means protruding eyes, could be suspected on scan as well. The others we can't. Then we have a microglossia, whereby the tongue is coming out. We see this in the profile view. We're not doing the profile view. You can see the tongue coming out, sort of not fitting within the mouth. Then we have, here we also have it, so we can't distinguish the two if our baby is macroglossia, just by macroglossia. This is all difficult. Long upper lip, we can see this on the profile image. Then we have cardiomyopathy, cardiomegaly here. Then we have ventricular septal defect, mitral valve prolapse, pulmonary stenosis, hypertrophic cardiomyopathy, arrhythmias. On this one, we have interrupted aortic arch. Then we have the tracheomalacia and all these other features that are coming down here. To save our time, so you can see that we can now match and say which condition more likely fits into our finding of all the conditions that are listed here. This is how we would determine, say, probably we may be dealing more with a Costello syndrome than maybe with a Beckwith-Wiedemann syndrome, because most of the features we are seeing here are consistent with the diagnosis of Costello syndrome. So that is on overgrowth. Let's assume that you want to use another feature on your scan finding. Let's assume that you want to use micronathia. Yeah, let's use probably micronathia. You see that there is a micronathia on your scan. Let's just see what micronathia. Yeah. So all these conditions have got micronathia. But for us to know then and say which condition, we come to clinical synopsis here. And once we are in clinical synopsis, then we check these conditions because some of the conditions are already described in some of the defects that are there. So you can say short stature, micronathia syndrome. If you have measured and your baby has got short limbs, probably you want to tick this condition and say probably it may be there. We can see the Meier-Golin syndrome. There is affection of the skeleton here. So just tick, just in case our baby may have one of these conditions. Then we look here, split hand foot malformations. Probably we didn't see much of the foot malformations. We may skip this one. Corpus callosum agenesis with impaired intellectual development and micronathia. Does our baby has corpus callosum agenesis? Probably no. Then Eunice Varon, Manzike syndrome, then Pierre-Robin. Probably there is something that looks like, and probably let's pick electrodactyl as well. Then we're going to compare these conditions now and say, amongst these conditions, which condition best fits the baby that we have just scanned. So this is how we are going to work around it. We go through this ticking and see which conditions has more of the features that aligns to the baby that we are scanning. Right. So let's assume that indeed we have now. Let's probably take a short stature micronathia syndrome. This one, or let's take Pierre-Robin. Pierre-Robin is one of the commonest. Talked about syndrome. Let's take, for example, Pierre-Robin. Let's assume that our baby has got a Pierre-Robin syndrome. So if we come to Pierre-Robin, where are we? Pierre-Robin. So we are going to choose Pierre-Robin. I will unselect the others. Then I'll remain with Pierre-Robin here. So if I go to Pierre-Robin, I will open Pierre-Robin. Oops, sorry, I opened the wrong one. I wanted Pierre-Robin there. Let me just go back. I hope you guys can see my page as I do this. Right. So that's Pierre-Robin. So Pierre-Robin, when you open Pierre-Robin, it's going to tell us the location of the defect. The location of the defect, if you check here, the gene loci, it will help us to inform the laboratory on what to check. Of course, if you write to any laboratory that, look, can you exclude Pierre-Robin syndrome, any laboratory can know. But if you are dealing with a condition which is not probably very common, you may have to mention the gene location which the laboratory has to target when they do genetic testing. So we will know that the deletion will be on the long arm of chromosome 17, region 24, subregion 3, up to region 25, subregion 1. So we can know where the deletion is, and this is the MIM number, the OMIM number, when you are mentioning it, because the OMIM number, people know these numbers internationally. So when you are talking about them, so that other people in other regions know what you are talking about when you are referring to the OMIM number, then this is the mode of inheritance to say, how do people get it? There's an autosomal recessive pattern to it. And this is the description of the condition. So you can read around and know more about the condition. This is very important for counseling of the outcome of the condition, and also the tests that can be done, and also for recurrent risk. So quickly, let's go through some of the overgrowth syndromes. Let's just start with the Beckwith-Wiedemann. So if we start with the Beckwith-Wiedemann syndrome, let's just go through it since we are on overgrowth today, to just illustrate. So this is the other name for Beckwith-Wiedemann syndrome. It's called exovalous macroglossia gigantism syndrome, or Wiedemann-Beckwith. Others say the opposite. So you may see it written as this or as this, is the same condition. This is the location of the deletions of the chromosome abnormalities here. And these are the OMIM number. It is inherited as an autosomal dominant condition. And these are the gene loci. In terms of the clinical features, let's go to the clinical features. Normally, it will present with exovalous, the macroglossia, the big tongue, extra-uterine. These individuals become giants. They will have gigantism. Then in terms of, they may also have umbilical hernia and visceromegaly, that is the liver, the spleen, the pancreas, the kidney, and the adrenal glands are all enlarged. What else? They may have renal medullary dysplasia and nephrocalcinosis and nephrolithiasis. They may have all these kind of disorders. All right, so if I just go down, let me just go down and see inheritance. We've mentioned that this is an autosomal dominant condition. These are some of the citations of people who wrote about it. So it's all full with citations. Then this is the cytogenetic testing that we have to apply whenever we see ubiquity. I mean, like I was saying, that you need to know the region. In this, in some cases there was a deletion. Then in some cases there was a duplication in the affected region. What else? Yeah. So this is more of the molecular genetic detail, which I will not bother you with because it's complicated. The molecular genetics, but you can see it's a very big condition, and you can read around. And this OMIM is available on your computers as well. You just have to go to the to your Google page and write OMIM. The first page will ask you to donate. If you can donate, please donate because they have no funding. This website is sustained on donations. If you can't, fair enough, you'll be able to donate maybe in the future. So that's Beckwith Wiedemann. If we go to Soto syndrome as an example, syndrome. Let's see. Where is it? Why is it not coming here? Why is it not coming? Let me just go to overgrowth. Let's see. Just give me a second. What time do we have? Let me just check the time. I don't know why it's not coming. Maybe my search criteria is playing with me here. Let's say overgrowth disorders. Will I see it? We are seeing Beckwith Wiedemann. Let's put fetal there. Just see fetal. Sometimes you might have to use a number of keywords to get to a certain condition, just like we are the way you do when you are looking for a research paper. Let's just say Soto syndrome. Sotos. Let's say Sotos. Yeah, it should be there now. Right. So let's go to, for example, Soto syndrome here. So it's showing us where the gene location is. It's an autosomal dominant condition, and this is the description. It will present as a neurological disorder characterized by overgrowth from the prenatal stage through childhood, with advanced bone age and unusual face with large skull, acromegaly, and a pointed chin, occasional brain abnormalities and seizures. But on our side of the scan, what are the features that we should look for beside the overgrowth? Let's just see what extra features we can get with the Sotos. Besides the brain abnormalities, normally Sotos babies will have a macrocephaly. Have any features? I don't see much besides the fact that they will have macrocephaly. There is nothing much on Sotos, and of course we may see some brain abnormalities on top of the macrocephaly with Soto syndrome. Right. So I think, what are the conditions? Let's go to, beside the Soto, we go where? Let's go to Simpson Golab. So this is Simpson-Golab syndrome. There are two types of the Simpson-Golab, but let's just look at type 1 here. You can see the XQ262. That's the location, and it's an X-linked recessive form of inheritance with type 1, and the commonest defect you may see with this syndrome is that there will be polydramnios. There will also be omphalocele, cystic hygroma, diaphragmatic hernia, enlarged or cystic kidneys, and sometimes agenesis of the corpus callosum. They may all be there on this syndrome. So yeah, so that's the rest of the information you can get. You can read around and know more of the condition. Yeah, I think I would want to end here. I'm not going to be exhaustive. I've shown the OMIM where people can read around more of the features of the different overgrowth syndromes. The OMIM does not just apply to overgrowth syndromes, but whenever you scan a baby with multiple congenital malformations, you'd want to apply the OMIM so that you know, besides the usual culprits, which are trisomy 21, trisomy 18, 13, and triploid E, what other genetic syndromes are likely? Because if you do the usual karyotype and the baby comes back as normal, but with multiple congenital malformations, certainly the baby may not be normal on its genes. There is need to use the syndromic approach and to request the specific genetic screening or testing for certain likely syndromes. But for you to arrive at that, you need to apply the OMIM on the condition so that you know which condition is more likely to be responsible. There is a lot that OMIM does, which I didn't demonstrate here, but I've demonstrated what I think is clinically relevant as you work, that you should know that there is this website, and this website should be familiar to everyone who is screening for fetal defects, because you should have an idea of these syndromes. And we want to begin to talk about these syndromes because I believe, even though if we are not able to do the usual aneuploid tests, we can still use the syndromic approach to try and give answers or likely answers to our patients while we are trying to develop as a nation to the extent of offering the same service as the Western world. So yeah, so in brief, I think this is it. I'll leave the room for questions. Do you have any questions to ask on the overgrowth syndromes? The overgrowth syndromes and the OMIM, we should also ask the OMIM to say how do we apply the OMIM. You can use any feature you find for the search. Then of course you have to match. Sometimes you might want to use more than one feature so that you narrow down your search. For example, we can say microcephaly, over that omphalocele. So in this case, it will allow us to pick condition that will probably have the omphalocele and microcephaly. You can see the condition that are coming: trigonocephaly, and so forth and so forth. So all these conditions will exist both microcephaly. You can increase the number so that you continue to narrow down until you have few conditions to compare, so that you have a set of syndromes with which to work with. So if we do not have any questions on the presentation, thank you so much. Next week, I will finish off on growth. I think we've covered enough on growth. Probably, if I think we'll try to gather some few case discussions to just check for understanding. I'll ask our senior registrar to prepare some cases. A few cases where we want to test the knowledge. So we'll be running more like a test next week. We want to check understanding. So we'll be running a test on Zoom where people will be answering questions as we'll be presenting questions and checking for understanding. So it will be more like a test, a post-test to try and check the level of understanding in all the participants on this. So it will be just a webinar. We'll run like a poll. It will be like a poll. So we'll be running and showing the responses that people have given. Yeah. So next week, we will do a revision of growth, but I think we've covered growth from all angles so that anybody who listens to these talks should be very competent and convinced in talking about growth disorders. So next week we'll be doing the test. Thank you. Bye-bye.